Welcome to Med Medicine with Miss P. Okay, well, today I'm not as jazzed up as I normally would be. I'm not all fired up about this particular video. I've done it before, and I just feel like it's going to be maybe a little bit of a repeat. Usually, when I was in the hospital consistently and watching people be admitted every day with CHF exacerbation, it was easier to kind of get fired up and want to scream about it because even the doctor's notes or their history or their talking to the nurses and going through that, it just seems like people in general don't understand how simple it is to get CHF and what it actually means. Congestive heart failure means you have congestion, additional fluid. You can have heart failure without congestion, but when the congestion comes in, the kidneys are involved. That's all there is to it. You can deny it, you can argue, and you can insist that's not a thing, but the kidneys are involved. Anytime you are on a medication, we talk about this all the time, but this is like the one thing people don't get. If your patient is on antihypertensive, well, then they have hypertension, right? And you're like, oh, it's controlled with, blood pressure medication. Even most patients or people can understand that. They can say like, oh, I have high blood pressure, but I take losartan and that, controls it pretty well. Or like I said last week, they'll actually type it in, blood pressure's controlled with this medication. And we're like, yeah, I know, I see that you're on it. Now, whether it's actually controlled or not, we'll find out as soon as I check your blood pressure. And when it's insane, we all know not controlled. But at any rate, if you are on Synthroid, you have a thyroid problem. There's no other reason you would be on that. If you are on lisinopril, you have a blood pressure issue. There are some other medications, we talked about this before, like propranolol. I'm gonna be like, why do you take that? Because you can literally take that for an array of issues. Hepatic or portal hypertension, ED, alopecia, for your heart as well as blood pressure, migraines. Like there's a million things. I literally will ask. There's certain medications that there's no point in asking. Now, and I've said this before, maybe one day I'll understand it or somebody will explain it in a way that I get it. I'll never understand a diuretic for hypertension. That doesn't make any sense to me, because if you are not getting rid of excess fluid or enough fluid, then that's a kidney problem, right? Because that's where those medications work. You can argue all you want, but none of those say at the capillary level, this is what it does. None of them say along the vascular wall, it does this or this. None of them do that. They all work in the kidneys, whether it's the loop of Henle being a loop diuretic or other areas altering the amount of reabsorption or excretion of certain electrolytes, right? Everyone's like, well, that's my water pill. No, it's your electrolyte pill. It alters the electrolytes, and then your body, then your vasculature, your kidneys themselves, then you will have a difference of fluid retention or release because of how we kind of pull the bull by the horns, right? So if you got a nose ring in this bowl, you can pull it anywhere you want. If you got it by the horns, you can pull them anywhere you want. Same thing that works with fluid, with those electrolytes. You pull the electrolytes around, the fluid's going to follow it. You got a hot chick, you're going to have 5 guys behind her, following her around. That's kind of how it works. It's not that tricky. So it works the other way too. Wherever Chris Hemsworth is, I would follow him to the ends of the earth and jump off the cliff like a lemon. So it doesn't really matter how what the reason for those medications are. They're going to do what they're supposed to do in that body, whether you like it or not. For those kids that are taking clonidine for ADD or ADHD, it's still going to alter their blood pressure. Now, is it enough to significantly change it to cause an issue, or do they have such a sympathetic nervous system spaz out that they kind of need that to help that situation as well? It does matter. It's going to do that in your body whether you like it or not. Now, doses may change that. Like I said before, if you take Cardizem 90 milligrams twice a day, yeah, that could very well be for just blood pressure. But it is a calcium channel blocker, so it's going to alter your heart rate whether you like it or not, but maybe not nearly as significant as 240 milligrams first thing in the morning. You have AFib. I don't care what anybody says. You have some arrhythmia or some electrical problem with your heart directly related to calcium, because that's how the med works. So if you take a diuretic, then you have some kidney issue. I won't necessarily ever understand the 12.5 or 25 milligrams of hydrochlorothiazide for hypertension, because just by getting rid of like some excess fluid, yes, you're going to alter the blood pressure, but that's not where the problem is. To me, I feel like that's a giant rug and you're sweeping stuff underneath it. I would sooner get to the root of why you have the hypertension. And that's a list of videos on a whole nother level. Maybe one day I'll get into that. But just in general, if kidneys weren't involved, then when someone came in with CHF exacerbation, we wouldn't give them IV diuretics. That's what we give you. You get IV diuretics. If you're home with CHF and everybody just insists, I used to work with a nurse that she's like, oh no, my kidneys are fine, it's my heart. And I was like, well, you take 40 of Lasix. That doesn't work on your heart. That's not a heart pill. That's not at all how that works. So you're like, well, my kidneys work fine. It's just that my heart doesn't pump well enough to help the kidneys get rid of the fluid. Okay, well then how's Lasix going to make your heart pump better to better perfuse your kidneys so they can work at their optimum level? Yeah, that's not a thing either. That's not how that works at all. Or if you have like severe pedal edema in CHF exacerbation and you come into the emergency room or you're in the hospital with it, we give you IV Lasix, we give you diuretics. That doesn't work in your heart, and it doesn't work at the capillary level. It doesn't go down to those capillaries and change your ionic pressure. It doesn't alter Starling's law. It doesn't do anything to change the amount of fluid shift at the capillary level until it goes to the kidneys. And changing the kidneys and how they reabsorb sodium and chloride, thus excreting those, all the fluid leaves, then like I always say, then the balance in your vasculature versus particles and fluid has to alter. So when you get rid of those excess particles, or not even excess, but when you have to get rid of those particles in order to balance that out, then your vasculature's goal in life is to stay isotonic, right? So when that changes and you become hyper or hypotonic, then your vasculature decides where to pull fluid to or whether to push fluid out. So at that capillary level, it's going to pull that fluid in from your edematous feet or your pleural, effusion, your pleural cavity. If you have an effusion, it's going to pull that in, and then you might have like a blood pressure change or spike. Or if it's getting rid of it fast enough, we can kind of catch it in between that, because no matter what, that fluid's going to come to the vasculature. We give you the Lasix, it goes away, and then that continues to cycle. So Lasix once a day, because it only lasts 6 hours, doesn't make a whole lot of sense. So when you're in the hospital and you're getting it every 6 hours IV, that means you have kidney failure. And I'll never really understand the BUN and creatinine thing. Even early on, before we really got into GFR, I thought, well, even if that baseline BUN creatinine is, the creatinine is like, 1.6, or they live at 2.1 or whatever it is, that is going to be altered by the amount of fluid in your vasculature, because it's kind of pulled per deciliter or however it's pulled. Like most of them are like per deciliter to an extent, but your GFR is really going to tell you what's going on, your glomerular filtration rate. So I started to kind of pay attention to that maybe about 6 or 7 years into teaching, and I thought, well, wait a second, their BUN and creatinine were fairly normal, and they talked in their dictation about their baseline creatinine and that sort of thing. But their GFR is 22. So their kidneys are failing, and yet nowhere did it say in the H&P or, in their history in general, or the patient themselves are like, no, say my kidneys are fine. Well, then why do you have all the excess fluid? Quit with the heart's not pumping correctly. I even had a little bit of a issue with a previous nurse who's like, yep, my mom stopped taking her dig and she blew up like a balloon. What? No, that makes so no sense. I can't even, I can't articulate that. If you think that if you give your mom get her back on her dig, all that fluid's going to go away because the heart starts pumping back again, and now you can perfuse all your organs correctly, so the kidneys kick back into work and then they get rid of that fluid. Okay, well, how about your pancreas? Did her blood sugar alter? Does she have LFT issues because we weren't perfusing her liver? Oh no, it's just that the kidneys weren't being perfused, but all the other organs. No, that doesn't make any sense at all. So when you took her to the emergency room because she blew up like a balloon after quitting her dig, what'd they give her? Did they give her a big dose of dig? No, they didn't. They gave her IV Lasix. That's what we gave. They gave her Bumix. They put her on spironolactone, hydrochlorothiazide, whatever. They gave her a diuretic, most likely IV furosemide, immediately, right? Because the problem is the kidneys. That's why we tell these patients, stop eating KFC. Stop eating canned soup and processed meats. You cannot take in salt and all of those other electrolytes that make you retain fluid because your kidneys are not working correctly. Now, how'd that happen? What I always tell my students is most likely it's been uncontrolled hypertension for a long period of time, right? So what ends up happening is, the doctors will tell you that you have white coat syndrome. Kill me now. The doctors will tell you that, oh, well, you're borderline, or and nurses too. And I'm not making fun. They all do it. You have. So you have borderline hypertension, or, we'll watch, or we'll keep an eye on it, or they put you on, 2-3 different medications and then send you home and say, take care. You're not checking it at home. You don't have anybody advocating for you. So, months later, your blood pressure creeps back up, as it does, or those medications only did so much to begin with, and you end up again being 200 over 102, and that's just normal, and your body's so used to it you don't even have symptoms. Nobody's telling you that it's a problem because you've been uncontrolled hypertense for so long. Now your doctor doesn't care a whole lot because he's out on his yacht right now. Meanwhile, you have permanent kidney damage. There's only so much your vessels and your delicate fibers of all of your internal organs can take being pressure clean. And then a lot of these people, of course, are diabetic also. Not necessarily in proportion, but when you combat both of those together, when you have both of those happening at the same time, you're not just pressure cleaning, but you're sandblasting. So all of those capillaries that, used to reach way out here have now exploded and basically just completely obliterated to where now you don't have that that perfusion distally. So those people still have, all kinds of numbness and neuropathy and problems because they have poor perfusion. Well, it doesn't necessarily mean that, your kidneys and everything right here don't have perfusion, or they're getting psychoperfused. You were just sandblasting all of those capillaries, and the arteries that are bringing blood to your kidneys are coming at such a high rate that it causes pressure also, consistent firm pressure over those delicate linings of your vessels are going to cause sclerosis and eventually stenosis, and you're going to have firm calloused vessels just like you get on your hands or anywhere else that is consistently pressurized. As well as, of course, uncontrolled hypertension creating that left ventricular hypertrophy, that cardiomegaly, the aortic stenosis, all of those things from that pressure and the bounding back and forth of the heart pushing against that pressure, your aorta being pummeled for so long that it becomes sclerosed or sclerotic, and it becomes firm, and now your heart has more pressure. It's a sick cycle. So if you don't get these things under control early on, you're going to end up on all these medications. In fact, I even wanted to look up that commercial. God, I hear it all the time when I'm listening to my my true crime videos. It's Cardenia, I can't remember, but it's like the ABCs of CKD. Oh, now you're talking about it, huh? Now that everybody has it, we're willing to talk about it. And I don't understand why people don't get that with congestive heart failure, you're going to have some kidney involvement. And what I find a lot is they're like, they'll, like I said, they'll say, well, it's because the heart isn't pumping well enough, and that's why I have fluid in my feet. No, the heart pumps for perfusion. It doesn't suck back. If you're talking about like that end diastolic pressure, that capillary kind of rebound pressure distally that draws that fluid back in, that's not from how hard your heart necessarily pumps out. There's a rebound effect, but it's also your vasculature trying to alter that, and your kidneys have to work to do so. So when your vasculature or those specific signals are sent to your kidneys to say, hey, get rid of this excess, or I need a little more of this, whatever it is, if they can get those signals all they want, if nobody's home, then they can't process that. So when we send a medication specifically to the loop of Henle, decreasing the reabsorption of sodium chloride, and we're excreting that, then the fluid follows. Then your vasculature can pull that fluid in wherever it may be, whether they have, just external distal edema, which I'll never understand why people think having distal edema means that it's because of their heart not pumping correctly. So I've always said this to my students, it doesn't make any sense. So you're saying like, people that have congestive heart failure, it's not that their kidneys have any issues. And I've spoken to people that insist they don't have kidney problems with CHF, diagnosed CHF, as well as being on, 6 day Lasix every morning. And in the hospital, we'll give it to you, every 6 hours, because that's about how long it lasts. and they'll deny all of that. So I'm like, okay, so you don't have more fluid in your body. You have the normal amount of fluid because your kidneys are working, so they should be getting rid of the normal amount of fluid, just like mine would, right? So all of your fluid is just like from your knees down. So you're like dehydrated from like thigh up. Is that what you're saying? So if you have the normal amount of fluid and it's all in your interstitial tissue and in your feet, then you just don't have any fluid in the rest of your body. Like your turgor and your legs are fine, but it really it's prolonged. It's poor in your upper body. Yeah, no. Now you can hear how dumb that sounds. I'll never understand it. It doesn't make any sense to me. And I remember about the last year I was teaching, I was watching these videos. Last 3 years I've been watching a lot of the doctors talking about stuff, that's been in the news. And one of the doctors, a world-renowned cardiovascular surgeon, has like the third leading number of published papers, in the United States. I want to say in the world, but I believe it's probably just the United States. On the way into work, I was listening to this, and I kid you not, he says, and I would tell you his name if you want to know. PM me and I'll tell you who it is. I don't know how controversial it'll be, but he's pretty amazing. I've been following him quite a bit, and he said, I'll never forget it. He's like, we're starting to really see that there's a correlation between chronic kidney disease and congestive heart failure. And I'm like, what? You're starting to see that? How is it not only common sense, but I pretty much figured that out a while back, and I am no smarter than the average Joe, not even a little bit. I just started to pay attention a while back when I started seeing these things over and over and over, like I told you in the past, when I started seeing all the cardio patients on magnesium, started to look into that. When I saw Synthroid and a diuretic, I started to look into that. When I see that all of these patients on H2 antagonists also have, IBS and got C. diff, I started looking at that. And it all just ties in real simply. Like there's no rocket science to it. Trust me, like I literally, as soon as I finished with my RN, I was starting to, carry on. I thought maybe I wanted to be, I don't know, I was going to, get my maybe NP or whatever, but oh God, that is way too much work. Like I can't. The word research makes me want to cry. Now, when I Google something or look it up or read an article, yes, that's considered research, but it doesn't feel like it because I don't use the word research. Or like the term paper, just like I have to write a paper, I have a paper due. I'd rather work outside in the sweltering heat for like hours without water. Like I can't. There's no part of me that wants to do it. So I didn't even realize that I'm kind of doing that as I went. But when I had 6, 7, and sometimes even 10 and 12 students, and they each had 2 patients apiece, that's a lot of research. I mean, I'm looking into that. Any student, previous student of mine, that I would go into that history and physical. I would print out a couple lab values and really dig deep. I would give you a report, and by the time you're done with the report, like this guy's favorite color and social security number, his childhood dog's name, and his first girlfriend's name. We would go all out. And when I started seeing it over and over and over, it started to just make perfect sense. And then when the B-union creatinine didn't really kind of tie in well, I was like, well, what's this GFR? And then on the GFR, it will literally show you, if it's this number, you have this stage kidney disease. If it's this number, you have this. And I'm like, well, I'm looking right here. Clearly it's stage 3 kidney disease. Why are they acting like in the H&P that he has no renal failure? Well, how is that not even on his CPT codes, the list of stuff to make him look as sick as possible so insurance pays? How come that's not on there? So I'm looking at all this and I was like, I can't be the only one that thinks that. And then sure enough, here this doctor is, and I told the students, like we had that morning pre-conference, and I was like, listen to this, and whoever was there, comment if you're watching this and you were there. But to me, it's very common sense. And like I said, you can have heart failure. Patients that have had previous MIs, AFib, lack of blood flow to that myocardium to where it's not pumping correctly and the electrical current isn't going through and their heart is kind of failing and they're on Sotalol and all kinds of antihypertensives. We want to bubble wrap that heart, put it in a padded room, stroke its hair, braid its hair, do everything to try to make this heart not have to pump it because that guy's got heart failure. His kidneys could still be working just fine. Doesn't mean that may not be in the works down the line, depending on how controlled this is. But when you have congestive heart failure, where does all the fluid come from? Do people with CHF, do they make more fluid? Do they create more fluid? Do they drink more fluid? Or are they just drinkers that they really, really go to town on the water? Probably not. They retain the fluid because it's not leaving correctly. Now, I've had this argument with previous doctors and some really sweet little anesthesiologists, and I've questioned them to the point where they're like, can you just go away? And I'm like, right, but do you see what I mean? Do you see how what you're saying isn't, it may not be something that's taught, I guess, or maybe I'm wrong. Anybody out there, listen, bring it up to me and tell me. I have no problem with being educated. I want to know how the kidneys couldn't possibly be involved when these patients are on diuretics, or even if they don't have congestive heart failure. But I talk to a patient and they tell me that they take 60 of Lasix or 40 of Lasix. How do you think that you don't have kidney failure or a kidney problem if you're on a medication to maintain your kidneys? If you take a blood pressure medication, then you have hypertension. If you take a chronic pain, a narcotic, it's because you have chronic pain. It doesn't make chronic pain go away. You didn't cure it. You still have it. That's why you take the pill every day. How do you know? How am I the only one? Am I the only one? I don't know. At any rate, I made myself little notes in case I got all fired up and missed some stuff, but yeah, I kind of think I got it all. That's the extent. All right. If you got questions or I didn't make any sense and you want to further discuss it, or you can teach me something, teach me. I'm always willing to learn. And that's it. This is kind of late in the day, so I got to go hop on a couple horses right now. It's 100 degrees outside, and I'm gonna go fight off the horse flies and sweat my tail off. So face your fears, forget your failures, follow your faith. Love y'all.